All right. Morning, everybody. Today we're going to just jump into sustainability in healthcare. So, whether some people will call this climate smart healthcare, some people will call this sustainable healthcare, different ways to have the right verbiage. But the overall goal is how can we be more sustainable in our practice as physicians, and how we can lend that to our clinics and our ORs and decrease that carbon footprint that we have in the healthcare industry. So overall, we're going to basically kind of say, what is the impact? So first we got to define the problems. We'll kind of define how much healthcare is impacting in terms of like waste and energy and talk about that. Then we'll really get into kind of strategies in terms of how we think about reducing healthcare's carbon footprint. And then a lot of this is just going to be on solutions, how to get engaged, what different levers we can pull or things that we can work on to try to move the needle. So if we just take a look at the healthcare system, in a sense, like how big is this problem? Is this a real big thing? Globally, if we take globally, the healthcare industry is the fifth largest emitter. And that's taking every healthcare system worldwide, right? So these are like when we talk about emitters, you'll hear facts from different people, right? And the facts are that the number one emitter is China. Number two is the United States. The number one emitter per capita is the United States. So those facts can get spun different way when, politicians or something will say, well, China's the largest emitter, it's not us. That's right, we're number two, but we're number one in terms of per capita, which is probably a better measure of what our impact is. But healthcare would be the fifth largest planet. And then if we say, what is that equivalent to? Like, how much is this really greenhouse gas emissions? Well, think of it like 500 coal plants running every year. So you can imagine, right? We kind of say coal's not a great idea, like burning coal's kind of dirty. And so if we can reduce some of that, we're going to have a systematic reduction in that carbon footprint that's affecting everyone. And we can do this on a global level, right? So solutions that we have in the United States, the cool part is they're applicable because we're all talking healthcare worldwide. So where does that kind of like, what does it mean for the United States? So if we say healthcare is the fifth largest emitter, or 5% of all greenhouse gases come from healthcare globally, in the United States, we're even better than that. 8.5% to 10% of our greenhouse gas emissions in our country come from the healthcare industry. So you can see on the graphs here, we are near the top in both. So that's healthcare or healthcare carbon footprint is HCF, defined as a percentage of the total carbon footprint. So only the Netherlands, it's always the Dutch, like they're number one, I guess, in this. But we are a significant emitter in the United States in our healthcare industry. And if you would take our industry in the United States by itself in healthcare, we would be the equivalent of the emissions coming from the 13th largest country in terms of emissions, and that would be the United Kingdom. So you can think like our healthcare industry is like the United Kingdom in terms of this amount. Even the National Academy of Medicine has come out and said this is a significant issue and they're trying to work on it. And we're seeing like 300,000 people dying of pollution every year. And if we're seeing those premature deaths from pollution, we're part of the problem. So it's something that we can make a dent in. So if you know that this is a problem, how do we assess a problem? Well, the first thing is you have to measure or see what you're actually emitting or where that percentage is coming from. And so there's kind of different ways that people can do this. We're going to talk about different scopes of emissions or whatnot. So you can look directly at something. So if I say anesthetic gases, I can say this gas directly emits in the production of it, and once it's emitted, it has a carbon footprint. Or I can say I throw away this glove. There is this plastic now or rubber that's going out into the environment. Another way to look at that is also like life cycle assessment. So a life cycle assessment takes from the beginning of the glove use. So, where is the glove made? How much energy goes into that glove? Where do they ship all the, you know, substances that they're using to put it together? What is all the equipment required? What is like the energy used to require those equipment? What is the transportation cost? What's the packaging cost? What's the transportation to the destination? And what's the breakdown component? So it's taking the full life cycle of something from beginning to end and all of the inputs. So it's a much better assessment, but it's really hard to do, right? Because if you imagine finding every item that we use in healthcare and tracking it from the beginning to the end, that's a lot of work, right? But we can slowly start to look at some of those and kind of assess where that CO2 is coming from. So when we talk um, emissions or carbon footprint, we can talk in terms of three scopes. There's scope one, scope two, and scope three emissions. Three different types. This applies to other businesses as well. So not just healthcare, but if you're in a different industry, you would look at these same categories of emissions. And we'll talk into scope one, two, and three. And as you can see on the graph on the right, scope three is over 80% of all our emissions. So let's get into all the different aspects of emissions that we are seeing in the healthcare system and what we're trying to measure to know what our true carbon footprint is. So if we take scope one emissions, there's a couple things that's involved. So one, any energy produced on site. So this is not like I have a power line from TEP coming in. It's like I have solar panels or I have a natural gas power plant on my hospital site that's sending power directly to my hospital. So it's not imported power from an electric company. It has to be generated on site. You would take that into consideration. So that could be a backup generator, right? And what is involved in your backup generator? How often does it run? That would be an emission that you would look. Any vehicles owned by that facility or company. So in a healthcare system, does the hospital own an ambulance? Does the hospital system own a car? You would take all of those fleet vehicles, add up all the emissions and the use of fuel, and that carbon footprint would go into scope one. Certain things like we tried doing this at Banner South. We found that there's no real fleet vehicles, but there are forklifts. So a forklift would be used, and the propane that runs the forklift was part of our emissions that we were trying to capture. Another scope one is waste anesthetic gases. So these are gases, right? So in anesthesia, Sevo or desflurane, isoflurane, right? We're putting those into the patient. It's in a closed circuit, comes out of the patient, and we vent it outside. So that just goes off into our atmosphere. The problem is those gases actually have an environmental impact, and each gas has different environmental impacts. So in the graph here, you're seeing looking at sevoflurane versus isoflurane versus nitrous versus desflurane. So desflurane, and this is something a lot of people have looked at nationwide in terms of how can we reduce our desflurane use? Because you can see the difference of footprint from it, right? 320 kilometers versus 6 kilometers. So it's a super potent greenhouse gas emitter. One of the things we did at our hospital, and a lot of hospitals are doing this, desflurane's not used a lot. So we actually went to the Pharmacy and Therapeutics Committee, the P&T committee, and we said, could we take this off formulary? First, we assessed our usage, and then we said, is this possible to take off formulary? And had gone to the anesthesia department and says, is it mandatory that you have to use desflurane? Like, is there like a set case that you just like, this is the best thing? And they're like, to be honest, there's alternatives. And so after we had that information, we then went back and were able in the winter of 2024, we removed desflurane as a anesthetic gas that we're emitting. So again, great. Now all those cases of desflurane have gone to SIVO, right? Or isoflurane, way less impact. And nitrous is a different one too, right? We're trying to talk about getting that in the ER. It'd be great to have, but there's also a greenhouse gas component with that, right? There's a carbon footprint that's going to be associated with that. And with a lot of these gases, you have to have circuits and everything. So the circuits cost energy and putting those in. So just anesthetic gases by themselves are a simple way we could reduce our, carbon footprint. And if you use SIVO over ISO, you're having your carbon footprint as well. So just knowing the impacts of things like that. And then refrigerants, right? refrigerants people don't think about, but this also includes things we call fugitive emissions. Fugitive emissions are emissions that are just kind of like leaking out. So maybe I have a nitrate or natural gas piping, and there's a little leakage from that piping. That's a fugitive emission. It's not being used for anything. It just kind of escapes into the atmosphere. The same thing with refrigerants would go into that. So whether that's a refrigerant for a refrigerator, refrigerant for an AC unit, refrigerant for freezers, things like that, whether it's storing food or medicine or different things, there's sometimes leakage in those refrigerants. So you have to include that in your scope one emissions. So that's kind of scope one. It's what's going on. We looked at it maybe like 10% of our emissions at most hospital systems. Scope two is easy. There's only really two things. One, purchased electricity. So I go to my electricity provider. I'm not generating this on site. I said, I need electricity. We have to take all that electricity and then say, okay, where did that electricity come from? What was the percentages? So here's some percentages from TEP, which is our electric provider. So the first one on the left, you can see natural gas, coal, TEP solar and wind, and then some purchased, which is 12%. So that is the mix that TEP provides over the year in its electricity that comes in. So that would be the emissions that we would state as our hospital. Here is our combination. Now you look on the right, they throw in private solar into that as well, because that includes, if we include the private solar that's allowed to be extra produced and not used on site, that would go into the pool of electricity that TEP is providing people. So you can see as more people do residential solar, maybe they don't use all of it, and some of it goes into the general pool. It decreases some of that natural gas consumption as well. So even a secondary wind helping clean our electric profile going in. And when we talk purchased, we've talked before, right? So you can, as a company, right, TEP can produce the electricity that they have, whether they have a solar field or a coal plant or a natural gas plant, and they own that facility and they produce that energy and send it into the grid. But they can also say, oh my gosh, we need more electricity. I'm just going to buy stuff from California. That's a better deal than me producing it on a cost basis. So, or I just need it because the demand is high for like AC units or something like that in the hot summer. So they go and they buy it and then that's just a purchase and they don't know what that percentage is. So they can't quantify like what it is. So they're saying it's just purchased energy. You can also, as an institution, have a power purchase agreement so a PPA with an electricity provider. So like the University of Arizona has a power purchase agreement that says we want this percentage of clean renewable energy as part of our portfolio that we're going to draw. So they basically say we're going to pay at this rate, we're going to purchase that, but we want like 25% of ours coming from solar. TEP then goes out and creates with solar providers and says, I need this much energy every year to meet this power purchase agreement, and they generate that, and then TEP basically gives it to like the University of Arizona. So you can have power purchase agreements that can change your percentage of what your purchase electricity comes in at. So there's ways to modify that. So purchase electricity, that's a scope two emission. And the second thing would be purchase steam. So things that you're using, why am I making steam in the hospital? Well, we need steam for sterilization, humidification in the hospital, so that everything's not dry from like AC units or heaters, laundry, and just providing hot water. So a lot of big buildings will have steam plants like this, and the firing of the steam plant is based on natural gas. So it's a natural gas steam plant. So whatever natural gas is used to run your steam facilities, that would go into a scope two emissions. So natural gas is used in that. Not a lot of these are electrified, but this would be a potential, right? If you want to have electrified steam production, and you could do that with a better electricity profile than just 100% natural gas, that actually could be a reduction in your carbon footprint. Scope three. Oh my gosh, everything else goes into scope three. So this this includes like any goods or services that's purchased. This includes capital goods. So if I build a new building, everything that goes into that building would be included. Or I remodel a bathroom. Every piece of equipment, every like the tile, the sink, all of that would go into a scope 3 emissions. Other things would be like fuel and energy for like related activities. So especially like business travel. So if Banner says, I'm going to pay to fly you to a conference, guess what? That's a emission that they would put into their scope 3 emissions. Or employees commuting. So every time employees commute to and from work, that would be classified in a scope 3 emissions. Also, right, this is a harder thing to do when I say like, all right, everybody tell you, how much energy do you use commuting to work? But it's incorporated into that. This is use of like pharmaceuticals. This is anything food purchases. So the cafeteria, all the food that they purchase, whether it's meat or grains or processed food, whatever they purchased would go into this. It includes the waste that the water used and the waste used. And so anything that we're sending to the dump, that would be included in this. Other things that we don't talk about would be like investments. So Banner as a company, whatever investment portfolio, and we're going to talk about impact investing next week, but whatever, investments they have, whether they're in like oil and gas or they're in like a solar company, that gets tied into their scope 3 emissions. So a lot goes into the scope 3 emissions. And that's what you'll see a lot of people trying to work on, right? It's the biggest percentage, it's over 80%, but it's so broad, right? Pharmaceuticals, devices, commuting, waste, procurement of what we're using. So all of these are areas that you can try to reduce to see if you can decrease your scope emissions for the hospital system. So let's just talk trash, right? I don't think anyone likes trash. You don't want to live near trash. People are like, oh, it goes in the trash and it goes away. It's easy if it goes away and you don't see it. But if what was like you walked by this every day going to work, right? It'd be a lot more impactful for you. You're like, okay, this is a problem. I don't want to be around this. But in the healthcare system, we're around trash all the time. I don't know if you guys have seen, our EVS workers are like going and constantly emptying trash cans and filling up like huge containers and going off to the dump all the time. So there's always disposable things, whether it's, we throw away gloves or gowns or, tubing or masks. Every package, everything we open, right, has a package and then that goes in the trash. So there's tons of waste. And sometimes it can be overwhelming. You're like, oh my gosh, this is way too much. What are we going to do with this? This is a picture from Maria Kojic, and she is a artist who did a 1 minute, like, and I can send you the YouTube if you guys want, but did a 1 minute video categorizing her breast cancer surgery. So she had her left breast removed and then had a reconstruction done from some abdominal tissue. And from that surgery, this is the waste that was produced. So she categorized it. There's vials in the middle and the beginning, and it starts going around to plastics and other parts. All the blue that you see in the ring are all gloves. There's orange sterile gloves as well. Then you get into papers and wrappers and all different products, gowns, gloves. This is from one surgery. So if you're thinking, she did a really nice job artistically to show this is the waste from a single surgery. How many operations are happening in a hospital every day, right? It's a lot. Is there a way we could reduce this? Are there some things that we can do that are reusable or decrease this impact? I think so. And I think that's kind of what we want to have in our mind when we're looking at like the scope of the problem, one operation, right? This is a big issue. Any questions right now on kind of scope emissions, just general waste and the impact that the US has in terms of its healthcare industry?
I threw one into the chat. I was just curious,
Oh yeah, go
what the
ahead.
percentage of like total healthcare waste comes specifically from anesthesia, like the volatile anesthetic.
I don't have a set number. I believe like the OR I think is in the 15 to 20% rate in anesthetics and anesthetic gases, I think are 5 to 10%. And a
Yeah.
lot of it, Tanner, has to do with the potency, right? So if it was just SIVO gas, that'd be a whole lot different than if it was like desflurane gas, right?
Yeah.
So it's like with everything, we take in what that waste is. and what that impact is, if that makes sense.
Yeah, I know. Because like the new chair for anesthesia here, I don't know if you saw, he came from Utah. And like on my interview there, and when I was on my sub by for grand rounds, one of his first talks was so Utah does like 95% of their cases total IV anesthetic,
Oh,
and
nice.
they don't use any volatile, well, 5% volatile anesthetic gas. And I think his goal is to move more towards IV anesthetic in the future. Um, I don't know like what the waste is of IV anesthetic. I'm sure there's still some because you're using syringes and whatever else you have to get rid of, but I'm assuming it's less than gas because they talk about it so much. Um, then my other question was for those power purchase agreements, is there any like requirements or oversight? Like, let's say 20% of people in Arizona have solar and there's an extra amount of energy that doesn't get used. I know they get rebates. Now, is that equally dispersed among the purchasers, like the 20%, or does the company then get power over the extra and can then dictate how they sell it? And are they required to sell some or do they waste some? Do you
Yeah,
know?
so good question. So with the power purchase agreement, it's usually with a company to a large scale, not a residential component. So
Hmm.
they're going to a large scale solar farm. Maybe the solar farm produces like 100 megawatts, and the power purchase agreements for requires like for the U of A to meet their percentage, they need 20%, 20 megawatts. So the solar field's going to continue to produce. They just allocate and say, okay, this 20 megawatts is going to go off to the University of Arizona. And then the other 80 megawatts we're off and selling on the market somewhere else.
Yeah.
Does that kind of
No,
answer?
yeah, it does. I was just kind of curious, like, because like let's say I'm the big company, right? And I have 20% of residential people having solar, and say half of those have a $0 energy bill because they have so much energy. Do I get to then dictate what I do with the rest? Like, do I get to sell it myself? I'm saying as if I'm the company, not the residential. And
Yeah.
then are there requirements that they use it or give it back, or can they just waste it? Like,
Yeah,
you get what I'm saying?
if you're a power company, you can do what you want with it and
Interesting.
sell it and use it. If you are as a residential owner, you don't get a choice. So
Yeah.
it goes right in, and then they can decide it doesn't, none of it gets wasted because it all goes into the grid. So
Yeah.
once you are producing that power, it goes into the grid. And then markets dictate who's going to buy it and who's an off buyer. Basically, selling at a price, someone is off buying at a price. There was a time a couple years ago where California had a few days that they were producing more energy than they could use,
Yeah.
and no one was taking it. They actually paid Arizona, and Arizona was paid to take some of that energy because you can't just like ground it. So they were just like, it's got to go somewhere. And so they actually paid some of the Arizona providers to take the energy. So it can
Yeah.
be kind of reverse for some of those power generators.
Yeah. Because when I was in high school, it's like 2006 to 11. I would go work in the summers at like different farms around Fresno, California, and there was huge like I don't know like discounts essentially to get into solar at that time. So all the farms I was working at were having like massive like solar panels installed and things like that. And I remember right as I was leaving, or maybe I'd come back from college and visit, some of those people were pretty upset because the original like deals they bargained for or whatever were supposed to be a lot more lucrative for them to do this, and they parceled out part of their land to do it. And then California changed the laws or the way they distributed the energy back to the people who bought it. So they no longer were like partners essentially, and they were just like upset with how the energy was getting distributed, and there was like no more benefit to basically having all the solar panels they put in.
Yeah. And it's usually with a company. So like the
Yeah.
farmers probably are
Hmm.
not paying for it by themselves, but they're paying a company to use, they're like leasing their land and say, okay, we get a percentage, but that company is going to be their rate's going to be dictated by the market. And
Yeah.
so the hard part is like California has a lot of solar projects, so sometimes it gets saturated to the point where the prices drop because everyone's producing, but you don't have a buyer. Uh,
Yeah.
Not in like heat season, but maybe in March. March and
Yeah.
April are big, like low energy usage, but high renewable productions. So
Yeah.
prices can go up
That
and
makes
down.
sense.
Yeah. Cool. Great questions. So we're gonna get right into solutions. And I want to like kind of as a framework or strategies, how do you work this large problem? And I think, this is a great kind of pyramid that says how do we do this? Well, I think, the first thing is like rethinking how we do it. I think Tanner was alluding to like rethinking how we do anesthesia, right? If I know a gas has this potential, but an IV anesthesia has a less carbon footprint, I could switch. But it's having the concept to say, I'm okay making a switch in my practice, or I'm okay trying a different direction, looking for an alternative that has the same results, but has less of a carbon footprint. So when, right, medical decisions or choices are similar, I think we should be looking at it through like a climate lens, which is a better impact for climate and thinking through that way. And part of this is gets into like what we're doing and how can we reduce what we're doing? Do we just need to rethink it? But the rethinking can lead to a reduction, right? There's a lot of over treatment in medicine, right? Most of our a lot of prescriptions or tests or procedures or costs are just over, like we're overdoing stuff. And so if we stop over treating people or calling diseases out and just saying like, oh yeah, this is a disease, you got to have this medication and it's super important, but it doesn't really make an impact, maybe there's a better alternative. Maybe we don't have to do a test on everybody all the time. And we choose the tests that are wiser or better, or maybe even a little more climate friendly, right? So it's rethinking when someone needs a surgery or a procedure, maybe reducing just the amount of electricity we're using, turning off lights or changing to LED light bulbs. Maybe it's reducing like the amount of paper in the hospital. Sometimes electricity and or electricity chart or e-chart is better or e-paper is better than just actual paper and handing that to people. And then after we reduce things, right, the reuse component. So what about reusable items versus disposable items? That's a big thing in medicine. So can we do things that are more reusable? What's the life cycle assessment on someone who's something that's reusable? What's the life cycle assessment on the disposability? So I bring this up in like laryngoscope blades is a common thing. I've tried to bring it up in my department, but Banner had switched from laryngoscope blades and then got rid of all the reusables and went to disposables. Why? I had no idea. I said, well, what'd you do with all those reusable? Well, we sent them to a country in Africa. And I'm just saying like, oh my gosh, like you just you came away. And there's good evidence and some papers that have actually looked at this. So the reusability, if you were to reuse a laryngoscope blade with washing and all the costs going into the life cycle assessment of washing and sterilization and packaging and everything, you would have to use laryngoscope blade, I believe, 7 times to make it useful as a reusable blade. Well, I think most reusable or laryngoscope blades get reused 7 times. The handle was like 17 times, and most handles get used 17 times. So the carbon footprint and the electricity usage and all the inputs definitely make more sense for reuse than disposable. But why are we there, right? We got to rethink it. And then are there certain things we can recycle, right? Recycling is always less. It's like, okay, I got no other use for this. I didn't reduce it. Let's find a way to do it. And then disposable, like instead of just throwing stuff in the ocean or throwing stuff in the river, is there a way we can do this, dispose of this waste product in a better way? So it's thinking about that. So let's talk about some local incentives. So these are some things right at Banner that we've run into. So one of the things that Yvonne Huckleberry, who's an awesome pharmacist at um, Banner University campus, but she works in the ICU, and so she's like, anything that gets taken out of the storeroom cannot go back in the storeroom. So say you go grab an extra device or something, you're like, I may need this for this patient, it can't go back. And we're like, what's going on? So we had to go to infectious disease. Like it never got open, right? The triple lumen catheter never got open. Why can't I just put it back and someone else can use it? So there were tons of supplies that were getting not used. We actually did an audit as well, looking at what was in a hospital bedroom, supplies that were brought to the room by the time the patient was discharged, what could have been used that was still in the room. And we were finding a couple $1,000s worth in a lot of these rooms over a week period. And so it's amazing, like, how can we find ways to get supplies back onto the shelf that haven't been used? Right? If it's not opened, okay, do we need to just wipe it off and call it clean and now it can go back? So we've worked with infectious disease to try to do something like that. Can we get these supplies instead of throwing them away? Let's actually use them. Other things we've looked at, expand. I think I mentioned we expanded our recycling. And when you do like a recycling program or adding a recycling program to an institution, you really have to work with your environmental services, right? Those are the people who are going to be managing it. We want them to be on board. So you're doing a teamwork kind of approach, like where are places that we should put cans? How would it best work into your workflow? So you actually, you're going and working with people when you're making these ideas or decisions or solutions, you have to work with the people who are most affected. We looked at like paper pill cups. So a lot of like plastic med cups get used once and then thrown away. Obviously, a plastic cup has a bigger carbon footprint than a paper cup. And so could we switch to that? One of the issues is cost, right? The plastics are really cheap. So a lot of times places use plastics. What is the cost per cup, and is that institution willing to pay for it? And it could make it on the waste side. Maybe we can decrease waste that way. Aluminum pill bottles. So instead of all those plastic prescription bottles, what if we used aluminum? They could be reusable. Aluminum is one of the most recyclable materials. It basically almost has an infinite life of recyclability. And then aluminum doesn't get any of those microplastics off into the patient. So maybe the pill bottle sat on the shelf. Maybe it was out in the heat for a little bit as it's going through the mail system. So some of those microplastics, something else that could be. We looked at silverware, right? This is the amount of silverware going through Tucson campus every week. That's a lot of plastic, right? So at South, we tried just at the cafeteria, we bought 15 like reusable silverware packets and put it there and said, okay, here you could buy these and use reusable and not just the plastics and throw away. They sold out. We put another 10, they sold out. We're ordering more, but it's just one of those things. And then I said, well, I'm like asking, what's our margin on that? And I think it may be like $4 a pair. So if we're paying for it, it actually becomes a money generating for the hospital. So when you can find a financially generating component, that's also beneficial, right? People are more interested. Well, what are we going to do with that money? Well, maybe now I can buy my paper pill cups, and slot the savings somewhere off to another place. There's a reusable pulse ox now. So Banner has instituted. So those, finger wrapped, pulse ox wires, they actually will keep. So you can take those and there's bins that you can throw them in, and the company is working with us to recycle those. So those are things, just again, another piece of trash. Let's take it out of the waste stream. Metal is in that, it can be reused. And then Gloves Off has been a big campaign ever since like you guys were in med school and you lived through COVID and stuff. And then in med school, we got to put gloves on for every time we touch a patient because patients have cooties and everything like that. Well, we really gotta, it's trying to rethink this training that's happened since COVID, and it's everywhere, right? If you go to a restaurant now, everyone's wearing gloves. If you go on an airplane and someone's like handing you the drink, they're in gloves. Like everyone's putting gloves on all the time. And the gloves have a significant environmental impact. Did you know like a gallon of water goes into every glove making? Just the making of a glove, a gallon of water. So that 200 box of gloves, 200 gallons of water went into that. That's a lot, right? And so it's a lot of water and energy and materials, and then they just get used once and thrown away. The problem is when we do gloves, what do we not do? We don't do good hand hygiene. So we're starting to see data on this. We're not washing our hands. We're not using hand sanitizer before or after seeing patients. And we're actually having a bump in infectious disease in the hospital because of glove use. So it's a dual. We're like infectious diseases on board with this, like reducing our gloves because it helps with hand sanitation and care. There's a straight cost, right? So Banner spent $220,000 at South Campus alone on gloves, you know? Or excuse me, no, sorry, $2.2 million last year. 2.2 million. We're looking to try to reduce that 10%, and that would save $220,000. But $2 million on gloves, crazy, right? There's a significant savings. Now, obviously, if there's blood, pus, nastiness, put gloves on. I'm not saying anything like, that. But how many of us like listen to someone's heart and lungs or push on their belly, or shine just a light in their mouth and aren't touching them, or shine a light in their eyes. Like, do we need gloves for that? Do we need gloves when we hand the patient a sandwich or hand them a gown or blanket? Probably not, you know. So it's just one of those things. Can you reduce the gloves that you're using? Simple campaign, it's been really hard to institute. So even though these things seem simple, like we have actually had an increase in glove use as we've started this campaign and trying to work on it. So difficult to do. Even with vaccines, right? The flu shot, there's evidence, and it comes out from the CD, not the CDC, but other infectious disease societies saying that you don't need gloves when you're giving someone a flu shot, right? You swab them, you go in with the needle, you inject it, and then you hand them a Band-Aid and they put it on. There's no transmission of fluid when you're swabbing someone and not when you're not getting your hands near the needle. Or could you use one glove if you're so concerned instead of two, right? Even making little differences and things like that. Filtering water stations, right? Talked about plastic water bottles. So on average, a liter water bottle, 240,000 plastic particles. And you're like, that a lot? Is this a real thing, Brian? And you're like, absolutely. And a lot of the nanoplastics we're actually seeing. So people in arterial plaques in the heart and in the brain and in the belly, we're seeing plastics in those plaques now. So you can imagine you're getting like, oh, I got a heart attack. Why? Oh, too many plastics, right? So there's an increase, it causes an increase in heart disease, increasing of stroke rates. They're even seeing nanoplastics and plastic particles in the brain and liver. So part of our bodies, if you want some weight loss, maybe I can decrease my plastics in my body and I'll lose a little bit of weight. So we put in refillable water stations and putting these in where you have the drinking fountains. Because like at COVID, right, a lot of people are like, I don't want to drink out of drinking fountains, but a refillable water station. And then trying to decrease the water bottles in the docs lounge, in the residence lounge. So we're not supplying with water bottles, but we're offering an alternative in that. Another part of this, maybe new employees get a banner water bottle. And so maybe we use some savings from the silverware. We get them a little swag when they come on board and they actually have a water bottle to use. And then one of the things we looked at was paperless new employee manuals. So they were making huge manuals, and some of our team said, I think we can just stop and give them a PDF copy of this. And so they did that. And so they're going to look at how much paper that they can save just by printing a manual that a lot of times people were throwing away. So different aspects that you can look at for local sustainable changes. And I know I'm hitting you with all different kinds of things, but I also want to show that there's so many different aspects to this, right? It's not that just one thing works, but if we start nibbling at the edges of all of these, someone may be interested. There may be someone in your clinic or your institution that says like, "Oh, I want to be on board with this." And we as change leaders, we can be the change in this. We can make by our decrease in consumption and our behaviors are going to influence people. So I have made a conscious decision, like with glove use. I used to just put gloves on because I didn't have to wash my hands. And I did it all the time. And I would put them on and take them off for every patient. And now, learning what I've learned, I'm like, I am hand hygiene, soap and water on a regular basis. And it actually is probably better and healthier for the patients. And patients like that too, because you just washed your hands before you saw them and after. So it's pretty good. Other changes, because you guys are going to be leaders, right? Can you bring in reusable containers, right? Maybe you pack your lunch. Maybe you bring in a reusable water bottle and you don't have disposable things. You're showing you're like, I'm committed to this. I brought my own silverware. I'm bringing not a disposable coffee cup. I have my refillable coffee cup and I bring that in. So little changes make an example. You will be influencing techs and nurses and pharmacists and other docs, and people may ask you questions about it. Great way to be the change, right? Your simple daily life and what you're doing on shift or when you come to work. I don't know have you guys heard of a Choosing Wisely campaign? Choosing Wisely campaign actually it asked every specialty for 5 things to make decisions for that specialty that probably don't need to happen. So certain things, like for the ER, one of the things was for people with back pain, they don't need regular x-rays, right? Unless they fell off a roof or something. But if I just come in with back pain, I don't need x-rays. So everyone had a bunch of different things that they said, this is a better practice of medicine. And so it's cool because you can learn from each specialty. We're like, well, you probably don't need to do this. Well, part of that is just reducing some of our practice patterns and rethinking what we're doing. But if to be really good physicians, the number one thing you guys should be doing is a good history and physical. And history is probably by far most important. It's rare that you can't get to a diagnosis without the history and physical. You rarely need tests. Tests are only there if you have a clinical uncertainty. But a lot of times people are like, oh, you have chest pain? Okay, I'll just put in the chest pain sets. Or, oh, you got this? I won't talk to you. I just want to like be done and I'll put a bunch of orders. There's a lot of cost to that. And, if people are worried about being replaced by AI or something, guess what? If you want to just order a bunch of tests, AI can do that very easy. But for you to make a good diagnosis, talk to a patient, do you need that test? Probably not. They got good color in their eye, their conjunctiva. I don't need a CBC. I know their hemoglobin's okay. They don't have any purpura. I don't think they have, any platelet dysfunction. They're not bleeding from their gums, right? Do I need that lab test? Probably not. Maybe I can just open up the wound and, they just cut themselves with a knife. I don't need to do an x-ray on that. And I could just actually look at the wound and see if how deep it is and go from there. So there's actually a benefit to making correctly and timely diagnosis with less resources, right? You get people out of the hospital faster. So you're not just decreasing greenhouse gas emissions by doing less. The hospital stay gets less. You get more patients in. You probably get more revenue from that for the hospital. And the hospital bills to the patients are less. When we do more, we slow down the system and clog it up. And that's one of the problems we have, right? So whether we're over-diagnosing things, over-testing things, we're actually hurting patients at a certain point, and we're hurting our climate, which also hurts our patients. So be good clinicians. That's a great thing for people to do, but we don't talk about that as a climate smart healthcare and trying to reduce what we do. Let's look at some individual stuff, right? Epinephrine. Epinephrine could be used, right, for anaphylaxis. So we give EpiPens to our patients. We're worried about that. EpiPens are like all these little plastic parts and little metal, and little vials and glass, right? It's a complicated little thing in that device. Well, how long does it last? 12 months? And you got to get a new one. And it costs lots of money. Not so cool. So nasal epinephrine, I don't know if you guys have got taught about this in med school, but nasal epinephrine's been approved. Neffy is the one that's a brand, but it is a single nasal spray, less materials, and it lasts for 30 months. So twice as long the last, that means only one device of Neffy versus two devices of NepiPen over the same period of time. I did a talk to the school nurses, and I found out that um, all Tucson Unified schools have now switched to stocking Neffy instead of epinephrine pens instead of the EpiPens in their school system. Another thing is a lot of kids don't necessarily like needles, so a nasal spray may be a little bit better, so maybe a good option. And then there's another company here called Houghton Designs, and one of the things they were looking at is maybe we could make a reusable EpiPen. So it actually decreased the energy going in, and they found some reusable parts of it. So those are all other alternatives, right? Maybe if I have a device, can I make some of that reusable and decrease the carbon footprint? So that's just like for epinephrine. What about inhalers? So a lot of you guys are going to go into medicine. We see a lot of people on inhalers. There are overall inhalers used to be chlorofluorocarbon based. So we switched to HFA, which is the gas in it. There's also now a dry powder inhaler. So the difference between an HFA inhaler versus a dry powder, as you can see here, is like a 98% reduction in carbon footprint if you use a dry powder compared to a, puff or inhaler. The other thing we're starting to see in the literature is you can actually use a long-acting beta steroid combo for both rescue and maintenance. So instead of prescribing someone their albuterol inhaler and then a steroid inhaler as two separate things, we could go down to one inhaler. So I've actually stopped decreasing my like albuterol prescriptions, and I do a lot more of the dry powder disc of a combo. So the one we use or I prescribe will be fluticasone salmeterol. This is Advair, Advair discus. It's a generic and approved by most insurances in Arizona. Other options you can use is just to go to a combo like a Symbicort, which is a formoterol combo. It comes on a little bit quicker, so maybe a 5 minute versus like a fluticasone salmeterol is like a 15 minute. So if people need to use it for breakthrough, but switching patients over to dry powdered inhalers, and people are like, well, not everyone can do that. You're right. Like younger kids can't do it. Certain people can't do it. But our VA system did it in our country, and only 1 in 6 patients failed. So if you think about all like the COPDers and the asthma and the adult population, if you can get a 75% conversion rate, that's pretty good. And that'd be a significant carbon footprint. So just changing our prescribing patterns. Other things we can do instead of IV meds, a lot of oral meds work just as well. So whether I give you an oral pain med or an IV pain med, the equivalency is about the same, and there's a lot less carbon input. Same with antibiotics, same with anti-nausea medications. We're actually going to see, I think, the IDSA is going to start to look at like osteomyelitis. We could just treat with oral antibiotics instead of doing an IV course for a prolonged period of time. Huge difference and stuff like that. We talked about choosing, disposable versus non-disposable. Other things like maybe you choose a reusable hemostat or needle driver or some component that's reusable. That scope you're using is reusable as opposed to the disposable one. Maybe you have access to both. Choose the reusable. Why not, right? It's easier. You're going to decrease the single-use plastics, decrease the waste. Other things like simple, this is an orthopedic, right? So if I have a boxer's fracture, we used to just do ulnar gutter splints. A lot of material in that. An Australian guy did a trial, recently said, well, what if you just buddy tape it? You actually got better outcomes. So you got more functionality, same healing, same long-term disability, but they had range of motion quicker. And so it's a lot less intensive than the old treatment that we would do, same outcomes. So why not do less? Also good to go to the psych ward if you're punching somebody. They can't go with a splint. So little things like that. So lots of different reusable items, whether it's operating room light handles, so all those handles in the operating room. We talk about surgical towels, safety belts, pulse oxes, we mentioned, lots of things, blood pressure cuffs. These are all big things that we could look at. Simple thing here. Another physician, I got a laceration. What am I going to do? Do I want to use a reusable Chuck's pad on the bed? Maybe I'll use some soap and water and a towel. Or I could just get a lot of trash and I could do the disposable Chuck's pads and some gauze and some sterile water. Well, we know with simple lacerations, you could do soap and water. It's cheaper, better, less carbon footprint. You can use towels. They get laundered. That's better than a gauze. And you can use a reusable Chuck's pad if needed. Simple choices, right? So why not? Why not make it climate friendly when the outcomes are the same for simple stuff? And then you guys can get engaged, right? Part of this is like, I want you to feel empowered that you can take some of this on. How can you engage with others, your community? Can you talk to your clinics or hospitals and be active members of trying to make that change? So not just the change for yourself in your practice, but can you explain it to others why you're making this change and why it's important? And then we talked about advocacy a little bit, right? Connecting with different organizations. So hospital systems, when they pair with organizations, you can do a group event or partner and get resources together. Even local communities, right? Hospital systems partnering maybe with a local community. We at one point had done a Clean the Rito River. So we had paired and went out and did a cleanup day in the Rito. Another day we made a community garden at Banner South, which basically took a courtyard and we said, well, let's put some rainwater harvesting and some trees and plants. The community garden thing didn't work, but now there's 5 big trees in there compared to just a straight dirt place. So provide some cooling for the building, a little carbon capture. So different things can not always go the way you want, but can turn out okay at the end. When you're looking to start some of this, know that you're going to need to get other people, right? It can't just be you alone. Who are your allies, right? Trying to find someone in the C-suite. Maybe it's the CEO, maybe it's the EXO, the VP of supply chain or something like that. Try to find some people who are like-minded who may be interested in this. Maybe it's going to further their career, right? Use whatever angle that you need to use, engage with them and say, hey, let's create a sustainability committee. And even if you can do the next one better, would to create a sustainability executive team. So you have a C-suite member whose main purpose is sustainability in the organization. And when we talk sustainability and why are you going to preach this to people? Well, go big, right? You're looking for cost savings, you're looking for a market advantage. Hey, we're the only renewable energy powered hospital system, or we practice green thing. You're going to bring in a different market for those kind of things. In competition, when someone else is doing this and you're not, you may lose that market share. So you want to try to spin things and advocate in a way that they're hearing. What are they listening to, right? And money always talks in hospital systems. And you can even mention the joint commissions, right? The joint commission comes in and does these surveys. They even have a sustainability certification that's not hard to get. You just have to measure three areas and show a reduction in them. But that would be another thing, right? Another feather in their cap that they can tote. Lots of opportunities for research in this. So if any of you ever have to do a research project or are interested in this, many research things. So we've written up a study looking at IV push versus IV piggyback and the cost savings it would be. The Chris Edwards, who's going to talk next week, has a oral versus IV antibiotic differences and outcomes for patients with urinary tract infections. You can look at cost effectiveness. Is this, what's the cost savings? Is there a time savings in terms of turnaround? Lots of different ways that you can look at sustainable healthcare. Simple stuff, right? We're going to do A versus B and see how it goes. And you can do that on a regular basis. Anything that you guys have seen or have any questions on in terms of things you'd like to see more sustainable? I know you guys are interested in this, but anything that I haven't talked about or thoughts that you have?
I had a question.
Hmm.
So I feel like with like certain parts of like critical care, there's like certain things that you can't really like negotiate on. So like a thing that came to mind was kind of like helicopter transports, because even with that, now you have like the emissions of the helicopter transporting, but like the other option would be like, okay, so like ground transport and they die, or like we just don't transport and they die. But I guess that's why you do like the acts of the gloving and like the spoons, so you make that a less risk. But I was wondering if there any is like another like option for that, or what people talk about with that.
Well, they do. And with like with anything, right, there's a harm versus a benefit. So the harm, right, may be a time component, but you also then, even if helicopter is available, is the weather okay? So there's places where the weather's not, suitable for a helicopter, even though it's faster, it would be more dangerous. So then you have to do send them by land. Or you can say, do I need to take a helicopter from Banner South to Banner University campus? It's a 20-minute drive, right? Is there a true time savings? And does that time savings matter for the disease? Or are we just trying to expedite getting them there because we don't want to deal with them? So it's thinking of what is the real impetus, right? Is it something that time is of the essence, or is it just like, this is a sick patient that's beyond our capacity? And we need to move them somewhere. And they may die in that transport, and we understand that. It's not ideal, but we don't have the ability to treat this anymore at our facility. So I think it's a balance of all of that, but definitely thinking about climate and trying to figure out, are there more sustainable, right? There's ambulances that are coming out that are going to be electric, right? So can I switch to an electric ambulance? And then you can say, well, are there electric aviation components? Absolutely, right? So they're looking at Joby and Archer and some other companies have kind of basically like large drone, which would be an electric based like taxis is what they're starting, like a four-seater planes. So would that be a future of transportation, right? That we go away from helicopters and we switch to an electric component of transportation for some of those. So I think a lot of that can evolve, but it's all decision making, right? It's taking all of these factors and thinking about climate as one other decision maker. I think it's just part of it. Does that help answer? All right. And I think, one of the things is just like once you see this waste, you really can't unsee it, right? You just start like now you look at a glove and you're like, oh, that's a gallon of water. You look at the trash can, you're like, man, that's a lot of waste again, right? What can we do? Like, how can we be better? And you start to see some of this and you can't like, oh no, it's not a problem, right? We're not going to do that. Just know that each of you are going to make a difference. Whether you think it's big or small, the waves you leave, we'll never know, right? You're going to have a wake behind you in your career, but you're going to influence a lot of people. And you are difference makers, and things that you do will make a difference. So overall today, we talked about the carbon footprint for healthcare, right? It's big worldwide, but it's even bigger in our country. We talked about all the different opportunities, whether it's research or QI projects or different like levers or ways that we can change, maybe rethink things, then we can reduce some of the things, recycling, right? We can work on education with people. We can work on the leadership of our hospital, create sustainability committees, maybe create a sustainability executive team. And there's lots of solutions. It's not like there's no solutions out there. There are so many for each of our specialties. We just need to implement them. And there's solutions that we don't even know that exist, right? We don't even know what we're doing is the actual right thing in medicine. We think it's the right thing, but maybe we're going to learn in the future there's a better treatment. There's a better alternative that's good for climate and for our patients. So thank you so much for letting me talk about healthcare. Any other questions?